everyone to this anesthesia training session. Today I will be talking about inotropes and vasopressors. So inotropes and vasopressors are two groups of drugs. We have several in each category. We have some that cross over both categories. And the purposes of these drugs are to correct blood pressure and support blood pressure in anesthetized and recovering patients in the ICU. So what are some reasons we might need inotropes or vasopressors in patients? Well, hypotension is one of the big 5 concerns that we have in anesthetized patients. And when you've tried other things like turning down the gas, giving fluids, and making sure that your patient is at an appropriate depth of anesthesia, sometimes it's going to be necessary to provide them with a little bit of heart contractility or vessel constriction to support their blood pressure. We like to say that blood pressure is a surrogate for cardiac output in dogs and cats. Now, this is not necessarily true when you look at the scientific evidence, but basically what we mean by saying those things is that the blood needs to flow to certain places at a certain pressure in order to deliver nutrients, oxygen, remove CO2 so that the animal can live. And low blood pressure is associated with all kinds of complications: delayed wound healing, prolonged anesthetic recovery, tissue death, arrhythmias, all these things that we do not want to happen. So these drugs are here to help support blood pressure, and each of them has different effects on the body. So these are reasons why you would need to use each drug very particularly and deliberately. So the first thing I want to talk about before I go through all the different types of drugs that we use here are the receptors that the drugs work on. So there are a bunch of different receptors that these drugs do work on. So I'll talk a little bit about their function up here. So these drugs are going to work on adrenergic receptors, so alpha and beta receptors. They are going to work on dopaminergic receptors, so that's D1 and D2 receptors. And there are other drugs which work on vasopressin and antidiuretic hormone receptors, which I will not be talking about today, but you would need to be aware of them if you are using that drug clinically. So the receptors, I will talk about kind of alpha, then beta, then dopaminergic. So alpha-1 receptor, so binding to the alpha-1 receptor, that is associated with the effect of smooth muscle contraction and vasoconstriction. So constriction primarily of arteries and arterioles. Alpha-2, so alpha-2 receptor activity, that is associated with sedation and analgesia. We are familiar with this because we talked about this in the alpha-2 agonist lecture a while ago. Beta-1 receptors, so beta-1 receptors, when you activate them, you will see an increase in heart rate and contractility. Beta-2 receptors, they are associated with bronchodilation, so dilation and enlargement of the bronchi and bronchioles. Dopaminergic 1, so D1, this is primarily associated with vasodilation of the renal circulation and the mesenteric, so the gut circulation, so increasing blood flow to the kidney and to the guts. Dopaminergic 2, that receptor, it is activated much less often than some of the others, but usually when this receptor is activated, we see things like decreased norepinephrine release, decreased ACTH, thyroid stimulating hormone, etc., those things. So a lot of these drugs have action at multiple receptors, but some of them have stronger action at individual receptors than others. And based on this, they are classified according to their primary mechanism of action. So if their primary mechanism of action is to increase heart contractility, that is an inotrope. That drug is called an inotrope. If their primary goal or their primary effect is increasing blood vessel tone, causing vasoconstriction of arteries, it is a vasopressor. Now, there are some that kind of go across both category and some that are a little bit dirty, so to speak. They go across multiple, so just be important to be aware of that. But with those things being said, I'm going to go through a couple of the different drugs, how they work, where they work, and some of the things you need to know about selecting those drugs. So when I say vasopressors, one of the first things that come to mind is usually epinephrine. This is one that a lot of us are familiar with. We're using epinephrine as boluses, high dose, low dose, and CPR. We are also using it in CRIs. So epinephrine has very strong activity at alpha-1 receptors. It does a very, very, very good job of constricting arteries. And it also has some activity at alpha-2, beta-1, beta-2. So it is a non-specific adrenergic agent. So it does not selectively work at one receptor, it works at many. Dose range is there. If I have something specific to talk about in dose range for these drugs, I will let you know. So, reasons why we use epinephrine clinically. So, the real reason why we like to use epinephrine in CPR is because it does something called increasing coronary perfusion pressure. So, the nice thing about this is that if you increase the perfusion and the flow of the coronary artery going to the heart in CPR, hopefully you're going to get that animal back. So, that is a common use for epinephrine. Epinephrine can be delivered as a bolus or as a CRI. The one thing I will say about epinephrine, that if you get it outside of the IV catheter, sometimes it will cause tissue necrosis because it has such intense vasoconstriction. That is something to be aware of. Another thing is that because it causes such strong vasoconstriction, the higher dose you give, the more you might reduce oxygen delivery to certain tissues. It also makes it very difficult for the heart to pump if the vessels are very constricted after the heart, which is something that epinephrine does really well. So the higher you get on dose, you might not necessarily get better cardiac performance. You might just get, more constricted arteries. And for the reason that epinephrine may decrease tissue oxygen delivery in those situations, epinephrine CRIs directly increase the risk of death in septic animals. So for this reason, when I have a septic animal that is having surgery or is being managed post-operatively, I do not usually choose epinephrine as a CRI because I am worried about increasing that animal's risk for death. That's just me. And everyone practices things differently, but I just wanted to give you that information and tell you why I make that choice clinically. I would call this drug almost a pure vasopressor, but it has effects at multiple receptors. Okay, norepinephrine. You've seen me use this all the time. Norepinephrine is also a vasopressor. It primarily has activity at alpha-1 and alpha-2 receptors. It also has some beta-1 effects, so not only does it constrict blood vessels, but it also increases the heart's force of contraction and the heart rate. Dose range for norepinephrine, at the low dose range, at this like 0.1 to 0.2 micrograms per kilo per minute, you're going to see a lot of increased contractility, increased strength of heart contraction, and some constriction of arteries. But the higher dose you give, the more constriction alone you tend to see. You don't get much more increase in contractility. And I would say almost across the board for these drugs which have mixed effect, that is largely true. At low doses, you usually get more contractility. At high doses, you tend to just have more vasoconstriction. And I talked about earlier with epinephrine, that does not necessarily mean that your heart performance gets better, because the tighter the vessels are after the heart, the harder it is for the heart to pump out. Okay, low dose contractility, higher dose more vasoconstriction. Norepinephrine is a great choice drug for animals that have what's called low systemic vascular resistance, or SVR. Basically what that means is low vessel tone. They're dilated. So what are some situations where animals are vasodilated? Anaphylaxis, sepsis, where you've tried drugs like Ephedrine or Dopamine or Dobutamine and they didn't work. Those are animals where norepinephrine tends to be very successful. So when the diastolic blood pressure is really low, like 20s, 30s, 40s, sometimes norepinephrine is going to be a better choice. I like using norepinephrine in septic animals. I also like using it in animals that are bleeding or dehydrated. And the reason why I do that is because norepinephrine tends not to make animals pee. There are other inotropes and vasopressors that diurese animals. So if you have an animal that you're worried about losing fluid or losing blood, you wouldn't want to give them a drug that makes them lose fluid more. So that's why I pick norepinephrine in bleeding animals. Okay, so that's the deal with norepinephrine. Dobutamine. So dobutamine is a different class drug. I would call dobutamine a positive inotrope. Its primary function is to increase heart contractility. It also increases heart rate, and it does this primarily by working at the beta-1 receptor. It's very good at that, and it has some beta-2 receptor effects as well. Dobutamine has a very wide dose range from 1 to about 15 or 20 micrograms per kilo per minute. So there are a couple things you do need to know about dobutamine when you use it. So dobutamine has no effects on blood vessel tone. But it does have effects on the contractility and the heart rate. So usually what you'll see when you give animals dobutamine is that the systolic blood pressure and the heart rate go up. The diastolic blood pressure is probably not going to change. So if you have an animal that still has a problem with their blood pressure after you give it dobutamine and you see that the diastolic is very low, maybe you want to give some agent that constricts a little bit just to kind of round out your therapy. So the higher in the dose range you get, animals do tend to get pretty tachycardic. Some are just more sensitive than others. Sometimes you're going to put an animal on dobutamine and the heart rate increases by 30 or 40%. And sometimes like the blood pressure just comes out gently with the heart rate. You'll just kind of need to see what works for that animal and do goal-directed therapy. But I will say that if you do high doses right off the bat, they tend to be very tachycardic. Dobutamine is an excellent choice drug for animals with systolic dysfunction, so problems with contracting. So when I talk about these guys, I'm talking about like the congestive heart failure dogs, the dilated cardiomyopathy dogs. That is a great choice for them because it works at that beta-1 receptor very well. So that's dobutamine. This is a drug I use less commonly, phenylephrine. So phenylephrine is a vasopressor. It has activity, very strong activity at alpha-1 and also some alpha-2 receptor. So it is an amazing vasoconstrictor. It does that very well. It's very potent vasoconstrictor. Dose ranges as described. So phenylephrine has activity at the alpha-1 and the alpha-2 receptor. It provides very strong vasoconstriction. So phenylephrine is a great choice for a couple different things. Because it's a very strong vasoconstrictor, it can be very good at reducing mucosal edema. So sometimes we can atomize it or spray it into horses' noses or dog and cat pharynx area, and it decreases edema and swelling. So that is a useful application of it. Because it is such a good vasoconstrictor, let's say you had an animal that has sepsis, anaphylaxis, very low diastolic pressure. If you tried drugs like dopamine or norepinephrine and they didn't work, you could certainly try using phenylephrine, but I tend to find that if an animal doesn't respond to high doses of norepinephrine, that does not necessarily mean they will respond better to phenylephrine. So you can certainly try it. It may not always work, but keep it in your toolbox as your backup method for controlling blood pressure in those bad situations where maybe you don't have access to something like vasopressin. So it is a pressor. Dopamine. This is a drug I also use very commonly along with norepinephrine. So dopamine is what I call kind of a dirty drug because it works at many different receptors. Dopamine is both an inotrope and a vasopressor. It is more of an inotrope than a vasopressor, but it does have both. So it works at alpha-1, alpha-2, beta-1, beta-2. And depending on what dose range you pick, you're going to see different effects from the dopamine. So, in addition to working at these receptors, these adrenergic receptors, these alpha and beta, dopamine also has effects at D1 and D2 dopaminergic receptors. So the nice thing about using dopamine is that it increases blood flow to both the kidneys and the gut circulation, which is great because if you have an animal with a kidney problem or a gut problem, the dopamine is going to directly increase blood flow to those areas by acting at the D1 and D2 receptors. So at low doses, I'm talking like 1 to 3, 1 to 5 mics per kilo per minute, you're going to get increased contractility, so beta 1 receptor. You're also going to get some alpha 1, which is vasoconstriction, and you'll also get some D1 and D2, so increased renal blood flow. So at low doses, you get almost every effect from that drug. The higher you go, when you get to 10 mics per kilo per minute of dopamine, you won't really see D1 and D2 effects. You'll primarily see alpha 1 mediated vasoconstriction. So let's say you start an animal on dopamine at 5 mics per kilo per minute. Blood pressure's not better. You turned up to 8. Blood pressure's still not better. You turned up to 10. If you get to 10 and the blood pressure's still not better, I would recommend maybe switching to a different drug or critically evaluating why your patient's blood pressure is low. Because usually there will be another thing you can fix. Maybe you just need to increase the contractility with dobutamine. Maybe the animal needs a fluid bolus. Maybe the gas needs to come down. Maybe your mechanical ventilation settings are too aggressive. So if you get to a high dose, just try to reevaluate and just see why that is happening. And if you don't know, it's perfectly fine to ask. Ephedrine. So this is a drug I used a lot during my residency, but I don't really use anymore. So ephedrine has effect both as an inotrope and a vasopressor. It is delivered mostly as a bolus. Pretty much all of these drugs are delivered as CRIs. So let me write some of this here. Bolus and CRI. Norepi, CRI. Dobutamine, also a CRI. Phenylephrine, it could be a bolus or a CRI. Dopamine, CRI. Ephedrine, bolus. Just an injection. So ephedrine has effect at beta 1 receptors, so increase in contractility, also effect at alpha 1 vasoconstriction. So that is its direct effect. Like when you give it, that is the receptors it works on, that is what it does in those receptors. But it also has an indirect effect. The indirect effect of ephedrine is release of catecholamines. So not only does the blood pressure get better because you constricted the arteries and you made the heart pump harder, but you also induced epinephrine and norepinephrine release from the adrenal gland. Now, if you give 2 or 3 doses of ephedrine, you are going to deplete the animal's reserve of catecholamines for a little while. So for that reason, this drug exhibits a property called tachyphylaxis. Tachyphylaxis means that after repeated dosing, you see less or no effect. And this is because that after you give 2 to 3 doses, you deplete catecholamines with ephedrine. So that also being said, when you give boluses of ephedrine to animals, if they are sensitive to catecholamines or they have a reason to have arrhythmias, they will frequently have arrhythmias after having ephedrine. So here is an example. During the first year of my residency, I was taking care of a German Shepherd with GDV, and I plugged my art line into the monitor and the blood pressure was 55. Ephedrine lasts half an hour. It's a great choice to give to an animal, fix the blood pressure, and have time to get settled, make a CRI of something else, and then get the animal onto that before the blood pressure comes back down. So I get in the OR, the blood pressure's low, I wanted some ephedrine. I gave the ephedrine to the German Shepherd, and because the animal was in a state of illness where it was susceptible to catecholamines, I gave it ephedrine, it released catecholamines from the adrenal gland, and the animal went into VTAC. So that doesn't always happen, but just be prepared for something like that happening if you have an animal that may be more arrhythmogenic than normal. So the last couple of things I want to talk about relate to how we would give these drugs and some general guidelines. So what I will say about these drugs is that some are given as a bolus, and that is what it is. and some are given as a CRI. So the reason why we give these drugs as a CRI is because we want to maintain a steady plasma concentration of the drug, and we also want to deliver tiny little controlled doses over time. Now, we talked about how some of these drugs, they cause vasoconstriction, so they increase blood pressure and increase contractility and heart rate. So if you give little doses over time, you get the effect you want. If you give a big dose in a short amount of time, if you bolus it, animals get hypertensive and tachycardic. So you don't want that to happen. So what you want to do with these particular drugs is, ideally, you would place a second catheter before administering these drugs. That way you can put all of these drugs in that catheter where it's never going to touch cefazolin. It's never going to touch propofol. It's never going to touch IV fluids. So that way, when you have to give the animal propofol or give it a injection of antibiotics, you're never going to be bolusing CRI. So it is my recommendation to place a second catheter and put a little extension on that catheter. My other recommendation is that, let's say you get in a situation where you decide to give dopamine to your TPLO dog and you just have one catheter. That's okay. But what I would recommend is, if you only have one catheter, when you need to give an injection of anything through that catheter, stop the CRI, clamp it, and then slowly give the injection through the catheter. You may still give the animal a bolus of drug, but at least that way you are more controlling the delivery of that drug. So that is what I would recommend. Now, let's say you do give an animal a bolus of these drugs. What's going to happen? Well, their blood pressure is probably going to increase and the heart rate's probably going to increase. It's probably going to last 20 to 30 seconds. It is probably going to come back down. And then your animal will probably be okay. So it does happen. I've done it many times. I've seen people do it many times. If you're monitoring them vigilantly, usually that goes over just fine. Now, something you do need to be aware of is a baroreceptor reflex. So we have talked about this reflex in context with sedatives like Dexmed. When you have such intense increases in blood pressure, when you get very hypertensive, you can have a baroreceptor reflex. So what that means is that if you give a bolus of one of these drugs and an animal gets very, very, very vasoconstricted, sometimes they'll get so vasoconstricted that the heart rate will drop. So that is something you do need to be aware of, and that is why it is very important to place a second IV catheter or to clamp the CRI and stop it if you just have one. So, in summary, different effects at different receptors for these drugs. I use them for distinct indications each. Epinephrine, CPR, but possibly increased risk of death in septic dogs. Norepinephrine, top choice for sepsis or bleeding dogs, in my opinion. Dobutamine, heart failure. Phenylephrine, great for reducing mucosal inflammation and edema. Great second line choice in anaphylaxis. Dopamine increases renal blood flow, but it does diurese them. It is a great first line choice for control of blood pressure. And Ephedrine induces catecholamine release and has affected certain receptors. And if you ever need a guideline on how to dose these or how to make these CRIs, a lot of these drugs do need to be diluted, but it's very easy. Just go to the anesthesia binder that we have in each of our hospitals. There is a dose range and indication for each drug, and there is also a way to dilute the CRIs based on weight so that you have all of that information. And that's it.